My name is Chloe. I'm a McMaster medical student. Do you mind if I perform the hand exam on you? Yeah, sure. Okay, that's great. Hello, my name is Chloe, and today we'll be doing the hand examination. Can I get the vitals? Okay, and I'll be starting with inspection. For the purpose of this OSCE examination, I will just be performing the exam on her right hand. In the real life situation, I'd also be comparing findings to her contralateral side. So first, I'll be starting with swelling. So I'm looking for swelling at the distal-radial ulnar joint, the myocarpophalangeal or the MCPJ, the proximal interphalangeal joint, or the distal interphalangeal joints. I don't see any swelling in this patient on the dorsal aspect, and then if we see on the volar aspect, I don't see any swelling noted either. Then I'd be moving on to erythema. So I'm looking for palmar erythema, and this would be suggestive of rheumatoid arthritis, liver disease, or hypertension, and none of which is noted in this patient. Then I'd be moving on to atrophy. So I'm looking for atrophy of the thenar musculature, hypothenar musculature, or interossei. So this includes interossei on the dorsal surface, the volar surface, and then the dorsal surface. I don't see any atrophy of any of the aforementioned muscles. Then I'd be moving on to deformities. So first would be Dupuytren's contracture. So this would be a fixed flexion contracture of any of the joints, namely the MCPJs or the PIPJs, which are not noted in this patient. Then I'd be looking for signs of osteoarthritis. So this would include squaring of the wrist, so you'd see this on mainly the dorsal aspect, as well as what's known as Bouchard's nodes at the PIPJ, and then Hubbardin's nodes at the DIPJ, which are not noted in this patient. Moving forward to the rheumatoid arthritis examination, I'd be looking for swelling in most of the joints except for sparing of the DIPJ. On top of that, I'd be looking for a prominent ulnar head, as well as radial deviation of the wrist and ulnar deviation and subluxation of the MCPJs, which are not noted in this patient. Sometimes I will also be looking for what's known as a Boutonniere's deformity, which would be a fixed flexion at the PIPJ with DIPJ hyperextension, which are not seen in any of these patients' digits, as well as what's known as a swan neck deformity, which would be a PIPJ hyperextension and DIPJ extension, which cannot be seen in this patient's hand. Moving forward to what's known as psoriatic arthritis, this would include swelling of the joints that does actually also include the DIPJ, which cannot be seen in this patient, as well as what's known as dactylitis in the digits, which cannot be observed. Moving forward to skin changes, so this includes psoriasis, psoriatic nails, splinter hemorrhages, gouty tophi, as well as any scars that would be suggestive of any surgeries or any previous injuries, which I cannot appreciate in this patient. So that concludes the inspection portion of this OSCE examination. Then I'd be moving forward to palpation. So first I'd be starting with general palpation. So this includes the ulnar head, which I'm palpating now, and I'm palpating in general for any pain or tenderness. Then the ulnar styloid, and then more distally, the TFCC. Without any pain noted here in this patient, I'd be moving forward to the anatomical snuff box for scaphoid tenderness, and then the abductor pollicis longus and the extensor pollicis brevis for any tendinitis. Then after this, I'd be moving on to the volar aspect and be looking for pain in the pisiform and then in the hook of hamate, which is not elicited in this patient. After palpating just generally, I'd be moving on to examine effusion. So first I'll look for effusion in the wrist. So this includes ballottement, and I'm looking for any fluid, fullness, and tenderness in the DRUJ, which cannot be appreciated in this patient. And then in the MCPJ, again at the just distal to the joint, I'm ballotting using what's known as the four-finger technique, and I don't see any fullness, fluid accumulation, or tenderness. Same thing at the DIPJ or PIPJ, which cannot be appreciated, and then the DIPJ, which cannot be appreciated. Then I'd be looking for flexor tendinitis. So this is pain along the flexor surfaces. So I'm just starting proximally and moving distally. I cannot appreciate any pain, and ideally I'd be doing this in all of the digits as well. So that concludes the palpation aspect of the hand examination. Then I'll be moving on to the range of motion. So first I'll have the patient just open their hand up completely. With the thumb out, I'll ask her to make a fist. Great. And curl her fingers in and open again. Great. So that's testing for flexion and extension. I'm looking for a range of motion about 0 to 80 degrees in the DIPJ. In the PIPJ, we're looking for about 0 to 100 to 120 degrees. And the MCPJ, we're looking from 0 to 20 degrees of hyperextension. So if I ask her to have her hand completely straight, you'll notice a little more hyperextension there. And then on the volar surface, as she makes that fist, I'm looking for about 90 to 100 degrees of flexion at the MCPJ, which I can notice here. And open. Great. So at the MCPJ, I'm also looking for abduction and adduction. So I'll get her to spread her fingers and deviate from midline. Great. And then bring her fingers back to midline. Great. And then I'll be looking now at the thumb. So the thumb being the most mobile joint in the hand, I'm looking for flexion, so towards the palm, and extension away from the palm. And then adduction towards her index finger, abduction away from the index finger. And then opposition towards her pinky tip and down. Great. And then I'm also just looking for circumduction. So this is moving the thumb about in a circular motion. Great. So the range of motion of her digits is quite normal. And then moving on to the wrist. So I'll just have her extend her wrist first and then flex her wrist. Good. So we're looking for about 60 to 80 degrees of flexion and extension, which I can see in this patient. And then after this, now I'm looking for radial and ulnar deviation. So I'll have her make a fist over her thumb. Good. And then just tilt her wrist towards her thumb. Good. So that's great radial deviation. And then ulnar deviation towards her pinky. Good. After this, I'm looking for supination. So I'll get her to open her hand and palm up and then palm down. Great. So that's great supination and pronation. And then I'm looking for circumduction as well. So just kind of in a circular motion. That's awesome. And then just in general, I'm going to have her hand in extension at the wrist and at the digits. And I don't see any fluid accumulation here that would be suggestive of tuck sign. So that's great for range of motion. So next I'll be moving on to reflexes. So first biceps. So just over here, and we'll have the patient relax her arm, which is great. And then triceps, we'll just have her hang her weight in my hand. And then brachioradialis, just over here. That's great. So then I'll be doing the sensory and motor exam. So first, radial nerves on the dorsal first web space, and then the median nerve, so the volar aspect of the distal phalanx of the second digit. And then ulnar nerve, again, distal phalanx, volar aspect of the fifth digit. And I'm assuming that these are all sensate in this patient. And then I'll be testing for their motor component. So this involves testing range against resistance. So first I'll just be starting with grip strength. So just grip my fingers. Great. And then I'll be testing for finger flexion against resistance. Good. Finger extension against resistance. Good. So it's the median radial nerve. And then finger abduction against resistance. Good. And then adduction against resistance. Good. So it's ulnar nerve. And then I'll be testing the thumb for flexion against resistance. Good. Opposition. Good. And then abduction against resistance. Good. And then, so that's the median nerve. And then we'll have her do extension for radial nerve. That's great. And then just in general, wrist flexion against resistance, median nerve, and then extension against resistance, radial nerve. So first, I'm just looking for general wrist stability. So I'm going to stabilize her hand using my left hand, and then using my right hand, I will deviate her wrist both dorsally and volarly, looking for any sort of laxity. So I don't appreciate any general laxity there. Then I'd be looking for the piano key sign. So for this, I'm depressing the ulnar head and seeing if it pops back up. If it does, that would be suggestive of radio-ulnar ligament instability, which we'd be thinking about rheumatoid arthritis. So I'll do that now, and I don't see it pop back up. So I'm not suspecting any rheumatoid arthritis there. After this, I'm now looking at stability of her joints. So I'm just going to have her MCPJ in flexion, and I'm deviating both dorsally, volarly, and then laterally. Great, so I don't see any instability there of any of those ligaments. And then the PIPJ, the same thing, dorsal, volar, laterally. I don't see any gross deviation. And then the DIPJ, dorsal, volar, and laterally, and I don't see any deviation in that regard. After finishing testing for stability, I'll be testing for carpal tunnel syndrome. So this involves 2 provocative tests, and they would be considered positive if it elicited any burning or tingling sensation in the volar aspect of the thumb, the index finger, the long finger, and then the radial aspect of the ring finger. So first is Tinel's sign. So I'll just be switching hands. So I'll be tapping over the carpal tunnel and asking if the patient is experiencing any shocks. And I assume that would be a negative. And then moving on to Phelan's test. So this has the patient kind of hold their hand in flexion for about a minute and asking if this elicits any of the symptoms, which I assume is negative in this patient. Next is de Quervain's tenosynovitis. So I'd have the patient hold their thumb in their fist and then ulnar deviate, so towards the floor, and ask if the patient experiences any pain in her first extensor compartment. This is the Finkelstein's test. If she did experience pain here, that would be a positive Finkelstein's test. However, it appears that it is not causing pain in this patient. Thank you for allowing me to perform the hand OSCE exam on you today. That has been the hand OSCE examination. Please check out the other videos for other OSCE examinations.